Hey, Dr. Moola,
Yeah.
can
Hi.
you tell me about rotator cuff arthropathy?
Oh, sure. What do you want to know?
So what is rotator cuff arthropathy?
I guess in a nutshell, rotator cuff arthropathy is arthritis related to a rotator cuff tear. So this is something that kind of develops over time, having had a patient having a tear of the rotator cuff. Decades pass by, the rotator cuff tear becomes much larger, and subsequently the change in force couples around the shoulder, the change in the mechanics of the shoulder leads to a wearing out of the joint.
So because your rotator cuff is torn and not repairable, it causes the arthritis?
In a way, when the rotator cuff tears, it changes the position of the ball relative to the socket. And typically a large tear is required for that type of change to occur. Radiographically, we would see this as elevation of the ball within the socket, and subsequently that mismatch of a centered ball in the socket, the ball riding on the edge and riding against the bone that's on top of the shoulder called the acromion, which is part of the scapula, results in wearing down of the cartilage over time and subsequently arthritis. And arthritis is essentially the loss of cartilage in one's joint, or in this case, the shoulder.
So what are some other things you might find on the x-ray?
You'll see the high riding of the humeral head. You'll also see changes to the acromion over time. So a descriptor called acetabularization of the acromion. Essentially what that means is that the acetabulum is the anatomy of the hip. The hip articulates with the acetabulum in the pelvis, and it starts to take on that type of form, meaning the acetabulum starts to round and contour with the shape of the proximal humerus. We can also see some changes to the humeral side as well. So as that humerus grinds down both the cartilage, it also can rub on the greater tuberosity, and it starts to look like a femur, and that's called femoralization of the proximal humerus.
Aside from the x-ray, are there any other imaging that you need for this diagnosis?
Rotator cuff arthropathy is typically a radiographic diagnosis. So in the extreme scenario where it's advanced arthritis, you probably don't need any further imaging. You can see radiographically that the cartilage has been worn down. You see bone-on-bone changes. You may see some of those findings that we just talked about with elevation of the humeral head, acetabularization of the acromion, and femoralization of the proximal humerus. And that in and of itself is typically sufficient to make the diagnosis. MRI could be done, but MRI would just basically confirm those findings and demonstrate that the patient has a very large tear of the rotator cuff.
Yeah. With regards to the patient themselves, like what are some clinical findings or what are some things that the patient may feel with rotator cuff arthropathy?
There's a multitude of presentations, let's say. Probably the number one thing that they would be experiencing is pain to varying degrees. And the pain likely will progress as the arthritic change progresses. So a patient presenting with more advanced stages of rotator cuff arthropathy would have more difficulty with pain, painful motion of their shoulder, painful sleeping at nighttime, which is a big reason for people to seek care once it starts to really affect their ability to get restful sleep. The other thing is going to be the functional limitations that develop as a result of arthritis. It can restrict range of motion. That balance that we were referring to earlier between the rotator cuff and some of the muscles that surround the shoulder, like the deltoid muscle, can subsequently affect how the shoulder functions, or how the arm raises above the head or rotates out to the side or rotates behind the back. And that degree of functional loss with movement will vary depending on the number of tendons involved, the size of the tendon tears.
Is there any classification system to see the severity of rotator cuff arthropathy?
There are a number of classifications, and the most common classification would likely be the Hamada classification. And we talked a little bit about some of the findings that we're looking for relative to the Hamada classification: the superior elevation, reduction of something called an acromiohumeral distance, or the height between the acromion and the humeral head, acetabularization, arthritic change. Those are all various things to look for on the x-ray that will then grading or the classification on that Hamada scale.
And how do you treat rotator cuff arthropathy?
Rotator cuff arthropathy treatment really depends on the severity. Earlier stages of rotator cuff arthropathy with preserved function and manageable pain, the patient may be recommended to work on some strengthening exercises to try and maintain the force couple as much as possible, maintain their deltoid strength, even in the setting of a large tear of the rotator cuff. Nice. Medications, over-the-counter medications would be another way of managing the pain, particularly, some nighttime pain. Anti-inflammatories may help with that. And then if the pain is becoming a bit more severe, the next step would be consideration towards corticosteroid injection, which is also an anti-inflammatory that helps to mitigate the pain.
And what if those stop working, and is there a surgical option?
For sure, yeah. These patients typically have a tear that's no longer repairable, right? So they're often older, like in their 7th decade of life, or sometimes beyond that. And we know that rotator cuff repair in the 7th decade of life, large tears, retracted tears, don't repair favorably, and the failure rate, unfortunately, if one were to attempt that, would be extremely high. So we no longer consider that the treatment of choice. Fortunately, over the past 20 years or so, and maybe a little bit longer coming out of Europe, but in North America, we've had the experience of using a reverse shoulder replacement for the treatment of rotator cuff arthropathy. And that's proved to be a game changer as far as options to provide patients, when before all we could possibly offer was a partial replacement, something called a hemiarthroplasty, which would help to a degree, but wasn't a life-changing type of surgery. Now, reverse shoulder replacement can help with the pain by eliminating arthritis on both the ball and the socket side of the shoulders, so that gets rid of pain. And then the second thing that it does is changes the mechanics of the shoulder, and it helps to rebalance some of those unbalanced muscle tendon groups to restore function.
So can you tell me more about the reverse and how that works?
Sure. I can tell you about the Enhance, which is a prosthesis that I use for a shoulder replacement, reverse shoulder replacement. This is the stem, so this would be the implant that goes into the humerus. Now you can see how it differs from a regular humerus. Instead of a ball on the top of the stem, this has a cavity or a cup. And that is the true reversing the shoulder. So you're reversing it from a ball to a socket on the arm bone side. On the socket side, we have to fix something to the scapula, and this is called a base plate. And it will help to adhere to the native bone, to someone's bone. You can see in fine detail that the metal that has been created, and this is 3D printed, the technology has advanced so much over time that we're making metal that mimics bone essentially. So a bone will grow onto this, and it essentially becomes part of the patient. We've also seen great advances in modularity in shoulder design. So in this case, we would be able to put a modular component of a ball onto the scapula, and then to this, the humerus would be connected. So you can see that there's now a reversed articulation. Essentially, if you can imagine what it would be like before this is placed, let's say this is the socket. The ball would be sitting up high in the socket. When we do a reverse replacement, we're effectively lowering the center of rotation, and that will, as a result, put a new tension on the deltoid muscle, even in the absence of the rotator cuff. And just to explain, the rotator cuff consists of 4 tendons, and each of these tendons have an individual action or role in arm motion. So supraspinatus tends to help with lifting the arm up over the head, as does infraspinatus. Infraspinatus and teres minor help with external rotation of the arm, and subscapularis helps bring the arm behind the body. Most tears of the rotator cuff start on the supraspinatus, so this we call the posterior-superior aspect of the rotator cuff. This can start small, and then over time they progress in size, becoming larger. It's analogous to like a tear of your pants or your socks, and with time, continuous wear, your tear is going to become larger in size, and then it starts to involve more tendons, and when it involves 2 to 3 tendons, then we start to see changes like we had talked about of rotator cuff arthropathy. You know, despite tears, the reverse replacement can change the mechanics, help to enable the deltoid muscle, this muscle that never really tears like naturally, to help elevate the arm up over the head and abduct it out to the side. And it does that quite effectively. There are 3 muscle groups. There's an anterior band, a middle band, and a posterior band of the deltoid, which aid in forward elevation, abduction, and some extension to a degree as well.
What are the expected outcomes in somebody who gets a reverse for a rotator cuff arthropathy diagnosis?
We're doing this primarily for pain. We can pretty reliably provide that with the technology that we have, a reverse shoulder replacement. We're replacing both ball and socket joint. There's no longer any native articulation, which can be painful. So pain mitigation would be relatively reliable and expected as an outcome of the operation. Range of motion and return of function is also something that we've been able to improve upon since the advent of reverse shoulder replacement. How much a person regains range of motion after the operation depends a bit on the procedure, the success of the procedure, how well it's done, some of the anatomy. Now we're getting into the granular details of how one does a reverse shoulder replacement, and that will affect the outcome. But it also depends highly on patient motivation, and their participation with physiotherapy.
Well, amazing. Thanks very much. That was really comprehensive. Really appreciate your time.